taking the time. Scott Lacey, your friend of Dr. Joe Alvarnas. Thanks for joining. Hi, John. Thank you. Paulo, thanks for joining us. And others, as you join today's live stream featuring Dr. Joseph Alvarnas. Give it another minute and we'll get started. Okay, let's get started. Well, welcome and good afternoon to the Leadership in the Age of Personalization live stream, whether you're joining us from Zoom or YouTube. I'm Glenn Yopes, and on behalf of GLLG, thank you for taking the time this afternoon to join me as well as we all interview Dr. Joseph Alvarnas, Vice President of Government Affairs, Senior Medical Director for Employer Strategy, and an Associate Clinical Professor in the Department of Hematology and Hematopoietic Cell Transplantation at City of Hope Medical Center in Duarte, California. Now, Dr. Alvarnas will also be a featured speaker at the 2020 Leadership in the Age of Personalization Virtual Summit on October 28th through the 30th. You can learn more at 2020summit.ageofpersonalization.com. The long and wide-ranging list of COVID-19 symptoms is a firsthand demonstration of how individualized our healthcare is and how personalized healthcare must become. No two patients experience the disease in the same way. Caregivers face the ultimate paradox of needing to follow rigid standards of care to maintain the highest level of health and safety while personalizing their approach to the patient that's right in front of them. Embracing humanity of a person-centered approach is not easy, but it's the most critical challenge we will tackle, as personalization is at the core of how we must change the ways we think about patient experience. Now, on the other hand of this equation, healthcare leaders are experiencing massive disruption and financial losses due to the pandemic, lost revenue, interrupted in unpredictable cash flow, pay cuts, unprecedented levels of stress for clinical and non-clinical employees alike. These are just a few of the many challenges facing healthcare organizations. Every level of operations has been affected. We need massive transformation, renewal, and reinvention across the board. Now, in a moment, Dr. Alvarnas will examine lessons learned from the COVID-19 crisis and the rapid evolution of personalized care at a time when patients want to be seen, known, and treated as individuals. Now, Joe will also address what transformation looks like and what resources are needed to make it happen now that healthcare has reached its tipping point. Now, this session is a Q&A session. It won't happen at the end, but rather throughout the program. Now, we have GLLG staff on standby. So to submit your questions, please enter them into the Q&A module on the Zoom control panel. GLLG staff will organize the flow of questions to ensure you could address your thoughts with an open mic. Now, before Dr. Alvarnas joins us, please watch the following short video from Joe's remarks at the 2019 Leadership in the Age of Personalization Summit.
We are human. We are born, we struggle, we live, we experience joy, we celebrate, and in time we die. And throughout that spectrum of the human condition and all the places in between, those of us in healthcare bear witness. We're privileged to bear witness to something extraordinary. Every moment of transformation, every moment is an opportunity for reaffirmation of those essential qualities that we embody as humans. Yet we find ourselves in a system for which humanity isn't the principal goal. At times we find ourselves struggling with commoditization and large scale and delivery of things that in their substituent parts have nothing to do with humanity. So how do we get from the metrics and mechanics to the dignity of the human being before us? So I'll give you some ideas. First, it begins by remembering that what we do is ostensibly human. We engage people at a deep level. So we begin every day, always, with a deep and enforced sense of humility. I am humbled by this experience. And here I'll tell you one of the doctor's secrets. The patient is scared. I'm scared too. I don't like cancer. I don't like losing. I don't like sadness. I know what it's like to hear a mother wail when she's lost her child. I don't want to hear that again. I've delivered 8 babies. I've pronounced at least 30 times that number dead. I stopped counting at 1,000 transplants that I've been involved in, but I don't forget the faces of every person whose care I've been privileged to deliver. So we can think about commodities and services and substituent parts, but that's not the part of healthcare that stands out to me. What stands out is the humanity of the experience. So my advice to you, I've done this now for 23 years, embrace the humanity. Because when it comes to the reality of taking care of the person before me, the most important skill is to shut up, listen, be humble, be present, and then sign on in the totality of where that journey will take you. Our ability to affirm the humanity of the person before us is at the heart of what we talk about when we talk about diversity. Diversity isn't generic. This idea of generic diversity is almost an affront to the individual dignity of every person whom we are privileged to serve. And it doesn't matter where you do it, how you do it, what your industry is, what your avocation is, what your belief system is. If we find and listen to that inner spark, that thing that gives light to the person before us, and understand their values, their priorities, the needs of their family, and the circumstances with which they find themselves, and we embrace that, we find ourselves in truly transformative places in healthcare. That's not easy. Being human is tough. We should embrace the toughness. Being frail is part of our existence. We should embrace the fragility of those before us. Because the journey forward involves recognizing the humanity within us, honoring the humanity in those before us in its distinctiveness, in its richness, and its full breadth of experience. And to the extent that we do that, remember that, and strive each day to fulfill that, we end up in an ostensibly different and more empowering place for all of us.
Joe, it is with tremendous gratitude that I welcome you today. And boy, I still get chills when I watch that video, and I've I've seen it at least 20 times. Thanks so much, Joe. I'm very, very grateful.
Oh, it's my pleasure to be here. Thank you so much for the opportunity to visit with you and our participants, and hopefully we can have a good conversation about some of the themes that you've touched upon in the introduction.
Thank you, Joe. Thank you. So, Joe, being human is tough. So what do you say about the families that have been affected, the patients that have been affected by the aftermath of COVID-19? And if it's okay with you, perhaps you could even answer this question by sharing a personal story.
Well, I think that, as you know, my experience with COVID is probably more personal than most. My wife and I and our family were all affected by this in early July. And there's a certain sense of humility that you get at feeling so powerless in the face of something so small, yet so large in terms of its significance for you. So while the rest of the household got by with a little bit of fever for a day or two, my wife and I spent a bit more than 2 weeks with 103-degree fevers, bone aches, as bad as any of I've ever experienced in my life. And a slew of symptoms that left you in a pool of sweat, fatigued, unable to think, smell, or really feel what you're about to do next. So the totality of that experience reminded me of the vulnerability that patients and families experience when they're traversing things far more daunting than even the coronavirus. So I leave with a greater sense of humility and much more respect for those feelings of frailty, vulnerability, and just not knowing what will happen next.
How do you feel now, Joe?
Better, more tired than I used to be, and need to go to bed earlier, but could be worse, as they would say.
Well, thank you for sharing that, Joe. I'm sure that's come as a surprise to our viewers, but that sense of humility and that strength that you're sharing before us now, hopefully makes us all pause to the impact of what this pandemic represents and really the totality of what's happening in healthcare. So, as you well know, Joe, healthcare has been on this journey of moving from volume to value, and patient centricity has been at the core of this shift. Now, given the lessons that we're still learning about the pandemic, what do you think, especially given your own personal experiences, Joe, what does patient centricity really mean? And how does this impact the value equation of healthcare delivery? I've got to believe that given how this has impacted healthcare delivery and the healthcare industry, we've been awakened to some new realities.
I agree. And I think that when we look at healthcare, and even in the midst of COVID, the profound disparities that you can find from community to community, I think it reminds you of a couple of things that we've discussed in our prior conversations. That standardization through rigorous guidelines and algorithms and even distillations of scientific facts pale at the human dimensions that something like COVID creates. And unless you're able to engage people on not only an intellectual level, but an emotional level, at the level of their communities, at the level of their families, and those who make a positive healthcare experience possible, then you've completely missed the boat when it comes to moving forward in any personalized way that will advance the art of healthcare. And the only other thing I'd add to that is, I spent a lot of my work looking at value in healthcare. And in fact, one of my job titles was Director of Value Analytics. And the first questions I'll pose to anybody from the government or even from commercial payers when they talk about values, what do you mean by value? Because it's not self-evident. And one of the things that I love that comes through these conversations, and maybe when we talk to people whose lives have been affected by the healthcare system, there's a unique moment here where people can empower themselves by taking the reins and defining value for themselves. Because it's just about creating metrics that can be fulfilled. It's about creating a system that fulfills people's needs and empowers them to seek their wishes and dreams and moving forward.
So Joe, I mean, as we've discussed in the past, I mean, behaviors don't change if the systems remain the same. So what needs to give here? I mean, because right now we know that the value equation is value equals Q divided by C, quality divided by cost, but who's really defining value?
Well, I think it's really tough to define value because it's so hard to measure the outcomes that matter most. So for someone who's traversing a cancer journey, survival matters, quality of life matters, the relationships that you enjoy and the quality of those relationships that you enjoy with your family and your friends matter. Our ability to metricize and numericize these things seems really very difficult as you get away from a transaction of care to expressing the value of a totality of care. And that's where systems have failed us. They think about the transaction and they value the transaction because it can be valued, enumerated, quantified, whereas ultimately it's the entirety of the experience of care, the restoration to wholeness, the fulfillment of that person's emotional needs, which probably play a far greater role in whether or not someone remains compliant with the treatment, whether or not someone asks the right questions when they're with the doctor, whether their family members are fully engaged to support them through the journey. So I think we measure the wrong things, and it shouldn't be surprising that we get to the wrong places by doing so.
So, Joe, thank you. You've sparked a question from the audience, and this one is from Aggie Cook. And so, Aggie, I'm going to have you take over the mic as you ask your question, please.
Thank you so much, Glenn. So my question is about the role of digital health and what role it may be playing in eliminating inequalities in the access to healthcare.
I love your question. I absolutely love your question because I think this idea of democratizing care is essential to getting it right. And I think that if you look at social determinants of health that play an essential role in whether or not people get great care versus sub-great care, I'm using that as opposed to the less polite version I can think of, that really barriers of distance, the physical distance, but also the economics of getting to a place to get the right care, you would think that electronics could get you forward. I think the problem that I've experienced in telehealth is that we take all the things that were bad about brick and mortar care and then build them into these devices. And what we don't do is create a venue for capturing more patient reported outcomes, more patient priorities in care delivery, more engagement of that individual's community in establishing goals of care. So until healthcare technologies and telehealth becomes beholden to a broader, more comprehensive vision of fulfilling that person's needs, it'll fail. And I'll just give you an example. My mother is here living in our house under hospice care. And she needed to make a telemedicine visit. So literally, I was holding an iPhone in front of her so she could talk to a doctor. And nothing, I won't say anything about the doctor, but this is not a great thing to do, is just hold a picture of a doctor in front of somebody's face and expect that to fulfill their care needs. A lot gets lost in the translation. And I think whoever in the tech sector can be able to take that cultural and functional experience of somebody's life so that the provider team understands the unique needs of that individual and facilitates it, then you've got a real product on your hands.
So did you have a follow-up, Aggie? Are you okay?
I'm okay. Thank you so much for answering the question.
Not at all.
So Joe, let's go back to this. So how do we bridge the technological experience with human connection? It seems to me that maybe you have some early warning signs as digital care delivery models begin to emerge.
I'll tell you the earliest digital warning sign was when they put computers in exam rooms, doctors began spending more time staring at a computer, clicking on it, than looking at the patient and speaking to them. And just the cues that we've developed throughout the entire evolution of us as human beings have involved listening to each other, looking at each other's, reading each other's expressions, developing that emotional intelligence, which we know is of such great value in creating resilient and robust organizations. And we're losing that by creating more and more barriers to that clinical experience. So I think that was the first warning sign. And to the extent that our system aligns economic rewards in doing more things that involve clicking and less things that involve just looking at the person before us, we're going to have not fewer but greater levels of disconnect between healthcare delivery and people's needs.
Thank you, Joe. Let me shift gears. Joe, why has COVID hit the Black and Hispanic community so hard? I mean, what action should healthcare providers take to really take these communities seriously now that, they're the most vulnerable to chronic disease states, in particular diabetes, colon cancer, heart disease, amongst others? I mean, we keep hearing about the numbers, but not about the actions. What are your thoughts on this?
I think I'll give you the best answer I can today, in part because there's so much about COVID that we don't know. So there may be biological things about COVID that I don't understand that may play a role in this, but clearly there is a huge impact of things which determine wellness. And you've talked about the prevalence of chronic conditions in traditionally underserved communities. You talk about and have talked about in our previous conversations the barriers to healthcare interaction. Some of that is physical distance, some of that may be economic, some of that may be infrastructural, some of that may be prejudice at the heart of the provider, not willing to engage in a more comprehensive assessment of the person's needs. But we see the burden of illness falling disproportionately upon underserved communities, I think at the very least because our systems repetitively fail them. And when you stress the system, it's not going to get better. Where those gaps have historically existed, I think will be exacerbated. And I think at least a large portion of the disproportionate mortality rates and morbidity rates amongst underserved communities reflects that our systems of care have not been designed to effectively engage and really embrace the needs of those communities.
So what do we need to do to start embracing them in a more intimate way? What are your thoughts, Joe?
I think there are a lot of levels to this answer, but I think at the very least, it requires a re-envisioning of what healthcare looks like. For so long, healthcare has been something that happened in a set of facilities. So people would get sick, they would travel to these facilities, and then they would either get good care or not get good care. But it was always, you had to travel to get something. And hospitals were something apart from the community. Healthcare centers were apart from the community. I think what you need is a fundamental realignment of care so that it begins with healthcare systems, personnel, facilities, educational resources being deeply a part, an ingrained part of a community, so that in the pursuit of wellness, these are valued partners. And then when people do have an illness or an accident or, God forbid, cancer developed, then healthcare grows out of something that already exists organically within that community rather than something that has to be sought out independent from that community. Because I think one of the things, you and I both come from immigrant families. One of those things that that we always saw when somebody got sick, everybody was there at the bedside. It was an entire community. And some people would take care of the day-to-day needs. Some people would take care of food. Some people would take care of the work. Some would help with understanding the plans. They would provide a reflective group of people to think through what needed to be done next. I think if we divorce healthcare from that community sense of us as human beings, then we end up with healthcare that's a fraction as functional as it should be.
Such a great point. And, the reason I bring this up is, as we know, and I'm sure many in our audience, that the reason these numbers are so high for Blacks and Hispanics, it seems to me, is that they've just been predisposed to other conditions. And they haven't been in the mindset of prevention and or wellness. And I just think that this is a wake-up call to whether you're on the payer or provider side, how we need to start examining these populations in an entirely different way. So anyway, Joe, let's shift. I'm going to go back to the audience. I know that you have there's some people here that want to, at the very least, say hello to you. So Megan, you probably knew that I was going to get you in the conversation. Megan, thank you for joining us. Would you like to take a moment to say hello to Joe or maybe ask him a question?
Sure, I knew you would. The question I have is more of a reaction to the discussion about telehealth. And I was reflecting on working from home. So I work in a corporate office setting. I've been working from home since March. And while the connection certainly is missing working from home, all of the benefits of being home, seeing all of my teammates in their environment, their kids, their decor, their children, their pets, I feel like I know better where they're coming from and who they are than I would have ever been able to when we were in the office. And so it's interesting, your response about that not coming through in a healthcare setting kind of surprised me, I'll be honest. And so I've been sitting here the whole time you've been talking, trying to rack my brain. Why are there the same level of benefits? Like in a corporate setting, I am missing the connection. So I totally agree with that. But it has been a bit overshadowed by all the other positives that for me, it's an acceptable trade-off, I guess. So I would love your thoughts on that.
I think that in part, when we have Zoom encounters with our friends, it's part of an ongoing relationship. And as you get to know that person over time, you're not trying to work within 15-minute blocks of pre-scheduled visits. You're not trying to work on some of the electronic health records activities that consume about 7.5 of those 15 minutes of a typical office visit. I think your focus is in upon your interactions. So that's part of it. Now, during this time, I've had some amazing phone calls with patients. I have a patient who underwent a bone marrow transplant successfully and was cured of his leukemia. He's now gone on, got married, had children, moved on with his life, and needed a kidney transplant. So we found ourselves on the phone at all hours of the day talking about what to do next. Part of why I think that works is that we have a pre-existing relationship outside of those constrained 15-minute blocks. I think on the healthcare delivery side, I'd like to see us be more creative with how we create these encounters, as opposed to when you look at how some of these visits are set up, they're set up beside a uniform background, they're delivered in a certain stereotypic way. And I think each one of those attempts to create standardization around the visit kind of undermines the personalization of the encounter. And that may be a not fully realized answer, but that's kind of what I wrestle with day to day.
Do you think that's a physician to physician perspective? Do you think that there are physicians that seem content with that, Joe? What are your thoughts?
I've talked to some of my colleagues who love telemedicine encounters and are really good at it. I've talked to others who are more uncomfortable. I think it's a paradigm change. And as you know, you can get very uncomfortable stepping out of your element. And I think that's kind of where we are in this realm of telehealth. I mean, up until 3 months ago, we were grappling with the HIPAA implications of using things like Zoom for clinical encounters. So I think that there's so many rules and regulations that we have to navigate that you often end up with a final service that isn't necessarily as engaging or powerful as what it could be.
Thank you, Joe. Thank you. Megan, did you have a follow-up for Joe?
I do. It was more the comment around, so I guess in the way that you're describing, having healthcare in the community part of your life before you need it is probably the root, root cause answer of, if my physician already knew me, then when we do get together, we don't have to go through all of what you're describing. I don't know how to solve it, but I think that just drives even more the importance of having health as a part of your community. So you aren't only calling a doctor when you get into trouble, which is kind of how it is right now.
Well, and I think one of the things that's often missing from how care can be delivered are these warm handoffs. If someone has a primary care physician or a nurse practitioner with which they've established a deep relationship, wouldn't it be nice to have that person and then the surgeon or the medical oncologist on the call together or on Zoom together and say, hey, I'd like to introduce you. This is Jack. And you have a conversation which makes it feel like that the essence of that human connection is being transferred through that conversation. Instead, we have these cold transfers which make the system seem more mechanical than maybe it really is.
Any other comments, Megan?
No, thank you.
No, you're very, very welcome. And so let's shift gears here, Joe. I know that Michelle Wynn is with us, and Michelle is very much involved in the personalization of care delivery over at CVS. Michelle, how about if you join us? I know that you enjoyed Joe at the summit. I'm sure you have a perspective or question that you'd like to share with him.
Hi, can you hear me?
Perfectly.
Yes. Great. Hi, Joe. Thanks for this session. It was that video so touching, and I agree with Glenn. It's something that I can't get enough watching. It's in times like this, it's so much more critical to have more empathy towards whether it's patients or customers or friends and employees. And so really appreciate that video. So in my space, within the pharmacy segment, we've been doing a lot of work on what we call what we call next best action, or another term is patient care personalization, where we want to target patient at the individual level versus at the segment level, where we group certain population into one group, and we target therapy in terms of interventions. So we have a lot of patients where they start therapies and then they stop. And in the past, we would group people together to understand why they stop, but we quickly find out that it's not, everyone is so different at the individual level. So we started leveraging big data and machine learning and artificial intelligence to start building out algorithms that would understand each patient at the individual level. And then we design interventions that work for that patient. So as you can imagine, the amount of data that we have to go through to build these models, these massive models. And it has proven to be very effective, where we were able to increase our patient therapy adherence rate by, we were leading in the industry when we were benchmarking with our peers. So it's very rewarding experience to see that the work we're doing is really helping people to get back on the path to better health. So I guess my question is, from the provider space, or from the medical community as provider, do you see, or are you aware of what's being done from the pharmacy side, or do you see the same intervention methodology being employed to continue to help patients be more proactive with their self-care?
First, I appreciate the model that you created, because I think it's a brilliant one that leverages data but links it to real human needs in a very tangible, very actionable way. And I have to just add that my own CVS pharmacy, where my wife and I were going after our COVID experience, people treated us so kindly and compassionately. So I think that you've created a model that's a wonderful one. As a clinician, I do have some really, I would say, powerful conversations with pharmacists who will say, hey, I just want to let you know your patient's not really taking this medication, or they express this concern to me, or we're finding this pattern in what they're doing. And that really, that helps a lot. And I think that relationship, by better and more closely linking pharmacists with clinicians, whether family nurse practitioners or physicians, to better understand why a patient might not necessarily be taking their medications, or an approach that might suit them better, has proven invaluable. One of the things that we find is that patients don't want to tell us that they're not taking a medication because they don't want to disappoint the provider. So the pharmacist may have a much deeper conversation about certain things that will never be broached in the office with me. So by closing the loop of information and having the pharmacist call and share that knowledge, it's been invaluable for creating better, more functional, more robust relationships with patients and families. So I applaud what you're doing, and I'd love to see it reproduced throughout our healthcare system, because you're the link to every community. I mean, literally.
Thank you.
Michelle, did you want to, I'm sorry, Michelle, did you have a follow-up?
No, I'm good for now. Thank you.
Excellent. Thank you. Thank you. So Joe, on that note, let's shift gears now. As the senior medical director for employer strategy, what role must large employers play in defining the future of consumerism in healthcare? I mean, because we all know that we're all in the business of health now.
Well, I think you've put it well. I think employers are in the business of health, even if they didn't think so before. I think that as healthcare costs have accelerated, and many larger employers are self-funded for management of their claims payments, that this idea of ensuring that for the amount of money that they're spending, which seems to increase year over year, that the impact of the lives of their members is a positive one, that it's reproducibly positive, that there's an opportunity there for them to learn and partner with others. In our instance, City of Hope and Access Hope, a subsidiary of City of Hope, which works in this space, has partnered with employers to try to do that. The other part of it is that the human experience that the HR person at large employers knows all too well, it has a broad impact. When someone becomes sick with cancer, it doesn't just impact that person or their family. That work unit may be substantially impacted by the absence of that person and the emotional nature of that experience. So part of being in the healthcare business means managing the emotional needs of those employees in ways that allow them to process their experience and move forward. So there are multiple levels that employers need to navigate, in part to ascertain and confirm that their members are getting optimal care, and then managing the downstream human impact of illness, absenteeism, and presenteeism that they may experience with patients, particularly, and I say patients because I'm a doctor by training, but especially when someone's facing a cancer journey or a serious illness or a chronic illness, the workplace, work unit impact of that can be quite profound.
Well, it's interesting you bring this up, because part of what I'm seeing is that large employers don't realize that their responsibility now is not just to get employees to do their work to meet a metric. It's now about being responsible for the totality, the wholeness of the individual, because of what you've just said, Joe. I mean, what we're going to see with mental health conditions, what we're going to see with the prevalence of other chronic disease cases that we don't even know about yet, because many people haven't been able to go and get care and understand why they're feeling the way they're feeling. It seems to me that we're about ready to experience a tidal wave of conditions that our employers don't even know that our employees have. Thoughts on that?
Oh, I think you've nailed it on the head. And I think as healthcare has gotten more effective, and it has gotten more effective, the dynamics of treating a population evolves profoundly. So I'll give you an example. 1 in 12 Americans are cancer survivors. That means that they may be subject to greater risks of COVID-19, for instance, things that we've talked about. They may have downstream complications like nerve damage or heart damage from chemotherapy. Moreover, as we get better at treating rheumatological diseases with these immune modifying drugs and treating chronic illnesses with increasingly effective therapeutics that may have broader implications, the population of tomorrow will not be the same as the population that we care for today. It's apt to be more complex, more dynamic in terms of healthcare needs. If the employer doesn't prepare for that, it creates greater risk of more dysfunction in the workplace, but also greater risks of unnecessary additional healthcare costs that if you build better systems, you could probably manage more effectively in a preemptive way.
So, Joe, in these partnerships that City of Hope is building with these large employers, do you have any sense that these large employers are ready for what's coming?
Some, yes. So I think that not every employer is the same. And there are some who, based upon prior experience, both personal and systems-based experience, they know that the complexities of healthcare are relentlessly moving forward and evolving at a dramatic pace. And in order to navigate that, I think they get that they need a partner. There are others who are beginning to see changes in the demographics of their employee and member population, as well as their healthcare spending, and anticipate that they're reaching a certain crisis point. And I think you see employers moving along that trajectory, particularly larger employers who are apt to see more patients with rare cancer types, things like acute leukemia, where resource utilization, patient outcomes, recovery from care, and even this whole phase of care called survivorship are something that they might not have had to navigate a decade ago when we had less effective therapeutics. So by improving the nature of healthcare, we also change the nature of the population that needs healthcare and has received it.
So thank you, Joe. We have another question here from Megan. So Megan, if you can go ahead and ask your question live, please.
Okay, so my question around the corporate responsibility of healthcare, what I've seen, at least here where I am, openly talking about mental health, ensuring that our employees and our teammates avoid burnout, staying safe. We've talked more about that in the last, 6 to 8 months than I think I've ever seen in my entire 20 years, which is great.
It's great.
It's awesome. I do think, though, as I'm not accustomed to my employer, I don't want to use the word intruding, but it does feel a little bit like that. And I think there are folks who are embracing all of the support that's available. And then there are others like me where I'm healthy. There are days I feel like, I could probably exercise more and drink a little less wine, but for the most part, I feel like I'm fine. And I think that is the general feeling. And so, but I don't know if that's the right one. So back to your comment about you've got to have healthcare in the community before you need help. And I feel like my company's trying to lay the foundation for that. But I don't know that it's being as embraced as quickly as I would have liked. And even I'm sort of a little skeptical. So I'd love your thoughts on what can we do to accelerate that? Because I think in my example, the large company is coming from a good place.
Well, first, I want to congratulate your company. I'd like to dissuade you on the wine part if I could. And I guess ultimately, we're all learning. This is a steep learning curve in which we're figuring out what works well and what doesn't. So I really applaud your employer for being present and available and more focused on these issues. I think figuring out how to be available and unobtrusive and non-invasive, but still able to interject is something that will take time. The easiest things to deploy are those things which I think are most intrusive. So being able to create a scalability of availability of these services to meet people's needs in real time, I think are essential. And if someone's basically doing well, like you are, then you don't want to get in their way. You don't want to you don't want to create issues where none exist. So I think that's hard to master. Now, I've found that some employers work with different vendors in the healthcare space that can provide services that allow unique expertise to be imparted at the right time and right place and on demand to people. And those who I think have deployed those things most successfully are those who create an awareness of them without bludgeoning people over the head with their presence. And it's a bit of a balancing act. Megan, does that answer help?
It does. I think even just the acknowledgement that finding the balance is difficult and reminding ourselves how much we've learned in the last 6 to 8 months, how much learning there still will occur, is a good reminder that just because you're right, the one that drives the highest awareness is also the one that is most obtrusive. And I think finding that balance will take a little bit of time, but I'm glad we're trying.
Oh, no, I appreciate what your company's doing. I'll give you an example from my industry. So physician burnout is something that was never spoken about. And up until this last December, I chaired the American Society of Hematology Committee on Practice. And as we became aware of clinicians really needing to develop some mechanism to manage these feelings of feeling overwhelmed, feeling depressed, all the emotions that comes with burnout in their job, we looked towards other experts in our field. And one of them rolled out a 2-hour module for people to watch a webinar on how not to be burned out. And I think we decided early on, that's not the path forward. So we have to find something that's more affirming and more resource directing and not so proscriptive and stereotyped, because that wasn't helpful. And it really missed the mark, particularly when it came to clinician burnout.
Megan, I have a follow-up question for you that perhaps you could volley back to Joe. But have you had these conversations with your colleagues?
You know, the only time we've had them so far, so for the team that I lead, it's mainly about if I think somebody could use the extra help. You know, so it's been more about need-based, and I think or if they've raised their hand and have said, is this available? Is that available? So it's still kind of need-based. Yep. I think for those that are healthy, it's a little bit of skepticism. It's water cooler talk. Oh, look, there's another, here's another webinar on, the one that I think is the funniest it was like a 90-minute webinar on how to be more efficient with your time.
Yes. Like the webinar and how not to be burned out. Yes.
Exactly. So I can relate, and I feel like it's a lot of I think it's just not something we talk about as often, and it's not normalized yet.
You know what, Megan, when I heard you say the title of that webinar, forgive me, but that felt like standardization was trying to solve for a personalized need. In other words, it didn't hit the mark.
No, I didn't even watch the webinar. I was like, I don't have 90 minutes to watch a webinar on how to be more efficient with my time.
Yeah, but the point is that's not what they're solving for. But anyway, I'm not disrespecting. I actually applaud the effort because this is a delicate space, and it's going to become more of a space of conversation that will be more accelerated as more people start experiencing not only their own chronic conditions, but that of their families. Go ahead, Joe. Did you want to intersect?
I was just going to, I think that the part of what we've seen with the advent of social media is people forming virtual communities around certain illnesses, around certain issues. And some of those companies in the tech sector that have done a good job of promoting awareness of new resources, either directed at burnout or directed at management of healthcare issues, are those who've moderated but helped these communities arise organically and then leveraging media within the companies to allow people who are interested to communicate, because there's no substitute for the authentic voice of somebody who's benefited from one of these programs.
Well put, Joe. Thank you. Thank you. And thank you, Megan. So we have another question here from Alfred. And we'll make sure that this doesn't get political, Joe. But Alfred, I'm going to put you on the open mic. If you could please ask your question to Dr. Joseph Alvarnas.
Thank you, Glenn.
You're very welcome.
Joe, this is ultimately about the ongoing litigation in the current administration related to Obamacare. And you look back 50, 60 years, medicine has been institutionalized, and we went away from the family practitioner, the general practitioner being the center of care, to now, quite frankly, the industry. And frequently when we go to get care, we think about deductibles and copays. So please share your observations about the potential impact of this ongoing litigation, how it might change coverage and or the level of care. And I would expect that many physicians do not necessarily factor that into the actual care rendered, but it certainly does have an impact. And then indirectly related, we have talked for decades now about a single payer system. And then you look at the countries that have those single payer systems, and frequently those that can afford it ultimately come to the US for their care.
Yes.
So again, ongoing litigation about Obamacare, the impact to cover or to the care rendered from a physician's perspective.
Well, so I'll speak as a physician first and foremost, which is when I see someone, or when one of my colleagues at City of Hope sees someone, we never look at their insurance. We just take care of them. And historically, we've enjoyed a robust charity care program for patients and families to ensure that they do get access to care. So this idea of care access is very important to me and my colleagues. And even as I look at the professional societies who represent large groups of clinicians, they do worry about any change in a law that might lead to the loss of access to care, because healthcare disparities are worsened when people don't have reliable access to care. And I don't know, again, these things go to courts, and courts can often come up with extraordinarily nuanced decisions. It's hard for me to presuppose what the Supreme Court might rule related to the ACA case, but I do worry about the potential loss of access to those who have established access under the enlarged Medicaid programs in the respective states who've chosen to do that. The issue of single payer healthcare could probably occupy many hours of discussion. I do have colleagues in the UK and Canada, and I'll just pick those two countries. And part of the challenge is that there are therapeutic technologies that in my domain of cancer care, things like CAR T cells, that's an immunological therapy directed at very refractory forms of leukemia and lymphoma, and pretty soon multiple myeloma. Those technologies are not offered to people in those respective countries because they're judged to be too expensive. And in fact, the UK has a board that looks at each healthcare technology and judges its appropriateness for actual utilization in the country based upon its costs. We haven't thus far had to grapple with anything in the United States, and I would be concerned about a system that, if applied bluntly, could disenfranchise people from potentially life-saving technologies. I've watched too many people die from leukemia and lymphoma to not feel passionate about new care technologies that could have saved their lives.
Thank you.
Thank you for the question, Alfred. Now, before we end, Jason, I know that you're also part of the healthcare industry. Did you want to jump in, or should we just close? I want to give you an opportunity to at least say hello or address a thought that you had to Dr. Alvarnas. Okay. So, Joe, as we get closer to closing, we've talked about healthcare reaching its tipping point. what's the industry and what's transformation over the next 3 to 5 years look like? What resources do we need? I mean, what awaits us?
Well, I think you've got a number of forces that have created this tipping point. It's people and their families saying, we need more, we deserve more. And it's not necessarily more care. It's more information. It's more opportunity for educated autonomy. It's more respect. It's more a sense that their needs have been addressed more fully. So you have that pull. On the other hand, healthcare is getting increasingly more expensive for a multitude of reasons. Some have to do with good things like the availability of technologies that can save lives. Another part of it has to do with care mismatches, people getting care that they don't really need and don't really benefit from. So between higher costs and the need for greater personalization of care, something needs to evolve. Now I do hope that telemedicine technologies help get us closer to meeting the personal and individualized needs of people regardless of where they live. I mean, there are, in as much as there are food deserts in cities, there are healthcare deserts throughout many communities where people struggle to get access to potentially life-saving care. We have to address those. And technology, if applied and designed correctly, and the design is key, could really help to ameliorate that. And I think by doing so, we can also help to meet some of the cost needs, that not everything has to be delivered in a bricks and mortar fashion, that community-based solutions may mitigate some very significant downstream healthcare costs of chronic illnesses that didn't have to happen, and if managed correctly, didn't happen. So I think they're great systems-based solutions. They involve probably a lot more creativity than metricization of current practices. So I have to think outside the box to get us closer to meeting patients' needs, and doing so in a way that honors the dignity of their humanity and fosters a much closer relationship between the healthcare system and the patient and their family.
Joe, what a beautiful way to close. Thank you so much for imparting so much wisdom and insight. Thank you to our audience for joining us today. And again, you could learn more about Joe's perspective around healthcare reaching its tipping point at the 2020 Leadership in the Age of Personalization virtual summit that will be held on October 28th to the 30th. Joe will be featured on the 28th. Joe, I can't thank you enough for joining us today. Thank you so much.
Pleasure being here, and I wish everyone a great day. Thank you so much.
Thank you so much. And remember, when you lead in the age of personalization, you will see things that others don't, do what others won't, and keep pushing when prudence says quit. Have a great rest of your day. Bye-bye now.
Bye-bye.